Good morning and welcome to the 2018 Epilepsy Grand Round Series at George Washington. Just a quick reminder for those of you who would like to have CME credit for this lecture. At the end of the talk, we will show a phone number that you can text with a 4-digit number, and you will automatically get the CME, which you can print online. For those of you who are watching us on the web and who do not receive updates and reminders about the talks, you can email us also to the email that will be shown at the end of the talk to include you on the list, so you can receive reminders and other announcements. The first talk of this year is by Dr. Cynthia Harden, which I'm truly delighted to introduce. Dr. Harden earned her medical degree at the University of Wisconsin and then went to New York City for her clinical training. She did internal medicine at St. Luke's and neurology at Mount Sinai, followed by epilepsy fellowship at Albert Einstein in the Bronx. She spent a good part of her career at Cornell, where she became professor of neurology before moving to Florida to lead the epilepsy program at the University of Miami. She returned to New York to support her daughter's career. Happy birthday, Julia. Sorry your mother is here, but she'll be back to New York later today. So she led the program at Long Island Jewish before her current position as director of epilepsy at Mount Sinai. Dr. Harden has contributed significantly to the epilepsy literature in all aspects of epilepsy, with specific focus on neuroendocrine problems in epilepsy and the psychiatric comorbidities of individuals with seizures. And in April 2016, she was elected as chair of the epilepsy section of the American Academy of Neurology, and she's also chair of the guideline subcommittee of the American Academy of Neurology. Dr. Harden.
Well, thanks to Dr. Kobesi for inviting me here. It's a great honor, really, to be here this morning and talk to you about sudden unexpected death in epilepsy. We are going to specifically focus on incidence and risk factors. These are the topics that were specifically addressed in the guideline that was published in April 2018. Let's see. I think most of these housekeeping things Dr. Kobesi went over. So my learning objectives today are to help you to learn the most accurate information regarding counseling epilepsy patients and their families regarding the magnitude of SUDEP risk, and specifically to implement SUDEP risk reduction by understanding and clinically managing the contribution of the risk factors to its occurrence. We're going to touch on understanding the mechanisms of SUDEP, although that was outside the scope of the management guidelines. So I want to just take a step back and look at more of a bird's eye view about mortality in epilepsy and try to think about how does SUDEP fit into that as a specific risk with its own specific, I guess, horror and emotion attached to it. But overall, people with epilepsy die at a higher rate than the general population. The standardized mortality ratio is the comparative risk measure used to assess the increased rate of death. It's defined as the ratio of the observed numbers of death in the epilepsy population to the expected numbers of death estimated by standardization to the reference population, those without epilepsy. So this paper came out in 2017, first author Thurman, the burden of premature mortality of epilepsy in high-income countries, this report from the ILAE. And as you can see, the standardized mortality ratio is about 1.4 to 3.6, with a higher standardized mortality ratio in children of 7 to 7.5. A similar study came out around the same time looking at middle and low income countries. Interestingly, the standardized mortality ratio in middle and low income countries was actually pretty similar. It was 2.6. So not that much different than in the high income countries. I want to show you this. It's an interesting landscape of death in people with epilepsy. It's really much greater in children and people under age 45, and then starts to approach that of the general population over age 45. So this is just people with epilepsy when they die in their lifetime, and the standardized mortality ratio at that age. Here's a graph of the years since diagnosis. So you can see here children, people who have epilepsy with onset in childhood, die at a higher rate than those with epilepsy who have had epilepsy for a longer period of time and have basically survived. So this really points to the severity of some of the childhood epilepsies, and you can see that one of the first SMRs I stated was 7 to 7.5 for children compared to 2 to 3 for the general population. Now, I want to point out some of the risk factors and associated factors with an increased SMR in epilepsy. So this is from high-income countries. You can see here children have a higher risk than the overall risk. Males and females about the same. Now these two dots that I put on this graph are not confidence intervals. They're actually just the range that was reported, the low to the high range of SMR that was what was found in this review. GTCs, greater risk than simple partial seizures. Those seizures that do not generalize, symptomatic, has a higher death rate than idiopathic epilepsies, and then comorbidities overall lend a lot of risk of death. And those include people with encephalopathies of various types, MRCP, brain tumors, obviously, cerebral vascular disease, and dementia here imparts a higher SMR. Having seizures versus being seizure-free, again, imparts a higher risk. SUDEP has a risk there that's actually pretty low in this study of an SMR specifically. Standardized mortality ratio, how many times more do people die from SUDEP? SUDEP, that's in patients who are treatment resistant. As I go on this morning, you'll see that treatment-resistant epilepsy is associated with a higher risk of SUDEP than the general population of people with epilepsy. There's actually no data about the SMR for status epilepticus in the general population in high-income countries. And here, the last part of this graph shows some of the things that we as practitioners could possibly prevent. Injuries by preventing, we could prevent death from injuries by preventing GTCs, presumably. Drowning by counseling our patients to be more cautious about swimming. Falls, and suicide actually is pretty high standardized mortality ratio of like 3 to 4. I actually put this on a log scale just as it kind of stretches it out a little bit so you can see the overlap between these risks and which ones actually are higher than others. Certainly the comorbidities lend a lot of risk to our patients, but outside of those factors, there are quite a few, there's quite an increased risk of death just related to treatment-resistant epilepsy and accidents and suicide. So we're going to focus on SUDEP. SUDEP is one of the most dire risks of having epilepsy. I'm going to touch on these factors. What is SUDEP? How often does it occur? Who is at risk? Where, when, and why does it occur? And I'm also going to use some of the slides from the AAN guidelines. And I'm telling you this because if you want to talk about SUDEP, you can use them as well. They encompass a lot of the process and the findings from our guidelines. So I'm kind of mixing these together. So when we started doing the guideline, the first thing we had to do, of course, is make sure that we had a definition that we accepted and that was present in all the papers that we used for the guideline. So, of course, the definition of SUDEP includes that it is sudden, unexpected, can be witnessed or unwitnessed. It is generally accepted as occurring in the immediate aftermath of a generalized tonic-clonic seizure. So how fast does sudden have to be is really the question. And in most, in papers that address the timing of SUDEP, when do if somebody has a seizure and they die the next day, that's not SUDEP, right? So it's about 20 minutes or so within the aftermath of a generalized tonic-clonic seizure. The patients have to have epilepsy. Deaths by drowning, trauma status epilepticus were excluded. Death could have occurred after a witness seizure. Other competing causes of death were excluded. Cases with autopsy to exclude other causes were termed definite SUDEP, and those who met the above criteria but did not have autopsy were termed probable SUDEP, and those are the only two types of SUDEP that we included as cases in the guidelines. Now, one issue when you review papers that discuss SUDEP is that sometimes due to the competing causes of death, patients over age 55, for example, are not included because it's thought that they would have too high of a risk of other competing causes of death, like cardiovascular. So just keeping that in mind, it kind of skews the data as well. That we may not exactly ever find out how the rate of SUDEP in people over age 55 or 60. So overall, who is at risk? Adults greater than children, as I'll show you, men probably greater than women, patients with generalized tonic-clonic seizures more than patients without, then patients with many versus fewer GTCs, people with ongoing seizure occurrence versus those who have had no seizures, who are seizure-free, that we would classify as seizure-free, for having no seizures for at least 1 year, patients who have not taken meds versus patients who are taking meds. So this is the incidence that we found for children, just one of the slides I'm going to present on this. And I want to show you, these are studies mainly from the US, and this slide shows the middle point that is the actual point estimate, and the ends of the bars are the 95% confidence intervals. So a couple of things about children is that the confidence intervals are pretty small, and the point estimate is pretty close, right? 0.19, 0.3, and 0.22. So we thought for the guideline that we had pretty good evidence about the truth of how often SUDEP occurs in children. And I just want to point out, because sometimes people ask this, they wonder, like, how often does sudden death occur in people who don't have epilepsy? And it's interesting. So in the infant population, which encompasses SIDS, the sudden death is pretty high, higher than this, at 1.5 per 1,000 patient years. In the general pediatric population, the rate can also cross over with these rates, but generally it's lower, 0.06 per 1,000 person years, actually. So dying of sudden death does occur in the general population at a rate for some studies that crosses over with the same rate of SUDEP. And these sudden deaths, of course, are generally considered to be cardiac in nature. Okay, here are some of the studies in adults. We ended up with 1.22, so that's quite a bit higher, 5 times higher than in children. And sudden death in the general adult population is actually at a rate of 0.92 from one study. This is only one study. There are other studies that were lower, but this I thought was a very good study due to the large population that was evaluated. So sudden death in the general population does cross over with the rate of SUDEP. So I discussed incidence rates a little bit, but we'll discuss them a little more, and then we're going to go into the risk factors. Now, I want to discuss the guidelines process. Before I do, I want to make sure, I know one person is interested in this. Are you interested in the guidelines process? Should I go over it? Okay, because I think it's interesting, but I don't want to bore you with a process discussion. But it's actually, you know, the approach to developing guidelines is really to find the truth from the literature, and that's a very tricky process. So we start with a clinical question that has to be formatted in the PICO format. Are you familiar with the PICO format? Anybody? Probably, right? Okay. Population, intervention, comparator, and outcome. So population, for people, for persons with epilepsy, does having generalized tonic-clonic seizures, that's not the intervention, but the comparator is compared to people without generalized tonic-clonic seizures, lead to a higher rate of the outcome, which is SUDEP. So for, you know, a lot of therapeutic questions, it would be, you know, more of a comparator. The comparator would be more like the placebo. For patients, you know, who have acute stroke, does after 6 hours, does thrombectomy versus not thrombectomy improve, you know, long-term outcome, something like that. So that's the way the clinical questions have to be proposed. And this is a prospective process. You have to make the clinical questions well formulated, because by the process you're not allowed to go back and change the questions based on the data that you find. You're like, oh, I didn't find, you know, I found something I didn't necessarily think we would find, but you're not allowed to go back and change the questions. Then we look at all the evidence. We do a literature search with keywords, and it's all very transparent, as you'll see if you read guidelines. Every word that was searched and every database that was searched is stated. And then the evidence is rated for the risk of systematic bias or systematic error. So that's how the rating for class 1, class 2, class 3, they are rated according to the methodology of the studies and somewhat on the transparency of the authors. Like, did you actually report how the study was blinded, how treatment allocation was blinded, how you know, the outcome was blinded to the treating physician but not to the assessing physician or assessing investigator. So these details need to be in the papers, and this is covered by most good scientific journals by the consort form. So this is how we rate the evidence on the risk of systematic bias. So then we take that body of evidence and develop the conclusions, okay? So a conclusion is part of, if we stopped and didn't make recommendations, that's a systematic review. It's not a recommendation. It's not a guideline. A guideline means that you develop a recommendation that tells people what to do. If you just make a systematic review, it just tells you, it puts forth what the evidence shows. So, believe it or not, until the last few years when we really incorporated the Institute of Medicine guideline process, we didn't have a systematic way of dealing with papers that were inconsistent. So how do you reconcile a Class 1 paper that shows one thing and two Class 2 papers that show something else? So developing the conclusions now by the grade process allows us to sort through that. So we do this by various methods, which is the systematic bias is really the first thing to consider. Class 1 paper is more highly considered as probably stronger evidence than a Class 2 paper. You need two Class 1 papers showing the same thing to say it is highly likely that blah, blah, blah works for, etc. If you only have one Class 1 paper or several Class 2 papers, you can only say it is probably likely, something like that. But also, what is very important in this, in developing the conclusions, is the precision of the papers. So this is where when p-values are reported, they need to have the 95% confidence intervals around them. So as you can see, when I show you the guidelines process, it's the strength of the data and the confidence in the data is influenced by the confidence intervals. You want the confidence intervals to be narrow. That's what I pointed out about the pediatric populations. They're very narrow confidence intervals. If you have wide confidence intervals, it means that there's random error, not systematic error, but random error. And what contributes usually to random error? It's usually sample size, right? The larger the sample, the smaller, in general, the confidence intervals. So if you have so the first thing to do to reconcile these disparate conclusions includes looking at the confidence intervals. Even if it's a Class 1 paper, confidence intervals are wide, that means you can't necessarily conclude anything about it. But if the confidence intervals are narrow, but still encompass the confidence intervals of the Class 2 papers, then you might be able to move forward and make a statement. So the strength of the conclusions is influenced by the body of work that includes, do they all actually go in the same direction? And also then we move on to this next step toward making recommendations, which is what is our confidence in the conclusions? So you have this evidence base that you have developed, but how confident are you that you can make a recommendation? So that's the next step. So one thing that influences your confidence in using this data to make a recommendation is the strength of the evidence, but things like the magnitude of the effect, a dose effect. You know, you take more of a drug and it gives you a bigger effect. That's supporting evidence that you should have confidence that this actually works. And also the generalizability. If the data that you have is a very narrow spectrum that you can't really apply to the general population, it's not worth making a recommendation about it, for example. And then also this is the point where, as we develop guidelines, we look at biologic plausibility. So for example, with the SUDEP guidelines, there were papers about phases of the moon and planetary alignment associating with SUDEP. So those did not make it into our recommendations because it just seems implausible at this point. So that's kind of things you can throw out at the conclusion stage. And then recommendations are made based on related evidence, based on biologic principles, based on the evidence, and then in the final process where the actual wording of the recommendation is developed, meaning, for example, a strong recommendation means clinicians must, consider so-and-so intervention for this type of patient. So that's a very strong recommendation, a level A recommendation. And we hardly ever get there because there are always considerations like as you'll see when I show you more about the SUDEP recommendations for nocturnal monitoring, can we truly, even though nocturnal monitoring may help reduce the risk of SUDEP, how can we really recommend to everyone that they should have nocturnal monitoring or have somebody sitting in the room with a patient who has seizures? It's not necessarily something that we can reasonably mandate. So those kind of things would lower the recommendations to something more moderate. On the other hand, if the risk to benefit ratio is very favorable, that we may upgrade the recommendations from weaker evidence to a stronger recommendation. So there's some wiggle room between the strength and confidence in the evidence, right, and what the final recommendation is. Does that make sense, or was that too much information? It's a long process. But for me, just having a process to take a disparate body of evidence and make it sort of into one statement about the confidence in the evidence is very important. Because when we did the Women with Epilepsy guideline, we didn't have a way to do that. It's like this paper showed this and this paper showed that. Well, how do we actually put it together? So this process has very much helped. So in this guideline, there were 1,068 abstracts. We ended up with 35 papers that we eventually used. We did put forth an inclusion criteria of n greater than 10. You don't have to have a number of to exclude papers in this process. You can have very small numbers of patients, but we used the n equals 10. We hardly excluded any papers for lack of definition because thankfully they mainly included a definition. We do not include animal studies. Sometimes we get this criticism at the guideline process, you should use this animal study to inform your recommendation or your conclusions, but animal studies are not part of the recommendations for patient management. So for the incidence of SUDEP, how do you have a high-level study? Well, basically what you have is you want a cohort of patients, a big cohort of patients that is representative of people with epilepsy. So how are you going to get that? Mainly you're going to get it from population-based studies. And usually those these days are from Northern Europe, where they have everybody pretty much captured in some kind of database. So those are very good studies. And the outcome for our studies, for our evaluation, is objective. It's death. You don't have to have a blinded investigator as to what the patient had when the outcome is so objective. The main thing is that all the patients, or at least 80% of the patients were evaluated for what happened to them. Now, this screening scheme where we developed Incidence, the systematic bias increases as you get populations that are less representative. So by the time you get to class 3, a referral cohort with a center that has a specialized interest in something, then you're not going to really get as representative of evidence. Class 4 would be did not include person at risk for outcome. For this study, for this evaluation, we did have some difficulty because there has to be a rate of SUDEP over time. If there's no measure of frequency, there's no denominator of time, you can't include the paper. And also there has to be a way to calculate the 95% confidence intervals. A lot of times we do this ourselves, but if you don't have the data, then if you don't have how many patients that were actually looked at, you can't really do that. So some of the papers were excluded for that reason. Now, we also looked at prognosis, which means risk factors. So a prognosis is an association, right? It's not a cause. So all we looked at was really an association. In this scheme, to be a class 1, it should be a cohort of patients followed prospectively, which is pretty unusual for SUDEP studies. There's one class 1 study by Silanpa and Shinar. And at least 80% of the patients have both the risk factor and the outcome measured. So 80% of subjects had to die, and at least 80% of the subjects had to be assessed for death, and of those deaths, they had to be assessed for SUDEP. And again, these schema go down in their class and increase in their risk of systematic bias based on largely, again, the population. A case control study is automatically class 2, cannot be class 1, because you already sort of enhanced the risk factors by using a case, which may generally be slanted to those patients with the disease that are maybe more severe. So that's why, and it's retrospective. So even though we learn a lot from case control studies, they can in general only be class 2. So I'm not going to go over that too much. Here's I already kind of went over this. Recommendations informed by the premises. So we always state what premises inform the final recommendations, which include the evidence, related conditions, axiomatic principles of care, and inferences made from one or more statements in the recommendation rationale. And you'll see how we came up with some of these derived from the evidence. So what is the incidence of SUDEP? Now, we are allowed in doing guidelines to do meta-analyses. A meta-analysis will reduce the effect of the random effects. But if you put into the meta-analyses class 1, class 2, class 3 papers, you can never have a high level of recommendation because it has to be anchored in the lowest level of the lowest classification of the paper that goes into the meta-analyses. We mainly had class 1 and class 2 papers to look at. And also to explore reasons for heterogeneity in the risk, we also conducted a meta-analysis on subgroups of patients, like children and adults. So I went over this already, 0.22 in children. And what is the incidence of SUDEP in people with childhood onset epilepsy, including SUDEP occurrences after adulthood? So this was 1.2 in this population, 5 studies. So our question really was, this seems a little convoluted, but this is in children, right, ages 0 to 18. But what you really want to know is you're taking care of an adult who developed epilepsy as a child. What is the incidence of SUDEP in that population? They're no longer in their childhood years. So that's the derivation of this question. What is the incidence of SUDEP in the general population? Now, the answer to this question is low confidence in the evidence due to considerable imprecision across the 12 studies. So our issues with the data was actually large confidence intervals. So that made us rate the evidence, our confidence in the evidence, as low. So I showed you the narrow confidence intervals for children, and that, although it wasn't thought to be as precise as one would like, that was rated as moderate confidence in the evidence. The rest, basically due to imprecision across these studies, the confidence intervals were wide, and we had low confidence in the evidence about these rates. Now here you can see the confidence intervals of the papers, and you can see the point estimates. And you can see at the top here we have 3 studies in children with the meta-analysis summary there in green. And the confidence intervals in general do overlap. For the adults, you can see they don't necessarily. There are studies that don't even overlap. For example, this study really doesn't overlap with this study. So you've got non-overlapping confidence intervals, so you cannot really have high confidence in this body of evidence. One thing that we could say, what we did say, is that it appears as though the rate of SUDEP is lower in children, right? The confidence intervals here are narrower, they all overlap, and they're somewhat lower, so we can say that the incidence of SUDEP is probably lower in children. In our one prospective study by Salanpa and Shinar, who looked at 245 patients who they looked at from childhood, and they looked at what happened to these patients over the next 40 years. They had 3 SUDEPs, I think it might be in here, and the youngest SUDEP was 16. So, you know, kind of points out that SUDEP appears to occur more with adolescents. So now this is a question that most of us have. What about people who have intractable epilepsy? The best way we could phrase this based on the evidence was, what is the incidence of SUDEP in the general population of persons with epilepsy who at some point in the course of their disease were likely difficult to treat? And this rate goes up to 1.5, again with very broad confidence intervals. There is one paper, which is a nice paper from England, one class 1 study on pregnant women with epilepsy. The rate of SUDEP was 0.79 per 1,000 pregnancies, actually, not patient years, but pregnancies. So we have that data. So here's, again, our overall incidence of SUDEP, and the confidence is low, childhood moderate, adulthood low. Just want to point out this study that came out just after our study from a database in Sweden, and they overall showed a rate of SUDEP of 1.1, 1.3, 1.13, 1.3 again per patient years in these age groups. The differential, you know, this is very similar to what we found. What they found that was much different than ours was this much higher rate in patients younger than age 16. We found 0.22, they found 1.11. So when I'm thinking about this paper, this is where you go back and you look at how did they actually do the study, considering that there were they are both very high quality studies. It's possible based on this methodology that they had better patient capture. You know, they had really accurate and complete patient capture. And so maybe their data is closer to the truth than our data. I also wonder if, sometimes Europeans are less aggressive with medication as well, and maybe they have a higher rate of SUDEP based on just their treatment approaches. But we thought a lot about why do people have SUDEP that increases at adolescence and early adulthood? That's what we found. And do we think it's biologically based, or is it behaviorally based? Is this the time when parents stop supervising their kids at night so much, or stop supervising them taking their medication? Or do they start partying and thinking they don't need their medication? We've all seen that many times. So, you see this data and you think it's somehow biologically based, but it could be just behavioral, and those factors are also something to consider about SUDEP. So these are our counseling recommendations for patients with epilepsy and their families. It's thought that patients want to be informed of the risk for catastrophic events, but can often overestimate that risk. Overestimation can be lessened by presenting the risk of the probability of having, both having and not having the event. So our language that we put forth was in this light. SUDEP typically affects 1 in 4,500 children with epilepsy per year. So 4,499 out of 4,500 children will not be affected. So this is one way that we can discuss the risk of SUDEP in children. And statistically, this is considered rare if it's less than 1 in 1,000. So although our job in writing recommendations was not to give people exact wording about how to discuss SUDEP, we tried to be helpful in our recommendations as to guiding counseling. For adults, 1 in 1,000 is statistically considered not rare, but infrequent or small. So small risk of SUDEP. 1 in 1,000 adults with epilepsy per year can die from SUDEP. 999 will not be affected by SUDEP. So you can see how we rounded these numbers and made these recommendations. So basically, they both have should, which is a level B recommendation. Now let's go on to risk factors. So what we found, as you're probably aware, is that generalized tonic-clonic seizures versus not having generalized tonic-clonic seizures increases SUDEP risk based on moderate confidence in the evidence from 2 class 2 studies. You may or may not be familiar with the papers by Hesdorfer, who looked at 4 different population-based studies for SUDEP. And actually what this group did, what Dr. Hesdorfer did, was go back and look at the primary data in each study and sort of recalculated everything as far as how many seizures the patients had, what drugs they took, gender, all the factors that we look at. And so even though she went back and looked at many studies and sort of compiled the information, they're considered primary data because she did a reanalysis. So in this analysis, it was found that having generalized tonic-clonic seizures at more than 3 per year versus 1 to 2 per year, this is GTCs, more than 3, 1 to 2, that there's an increased SUDEP risk of 3-fold. So this actually gave us a highly likely recommendation, a highly likely conclusion. You know, this is like a dose effect, right? So it gets the conclusion to a higher level of confidence. Why does SUDEP occur? Generalized tonic-clonic seizures carry a risk, and the higher frequency carries more risk. So these, again, are Hesdorfer. So I think it's important when I talk about 3 times the risk to look at actually the odds ratio. So the risk of having 1 to 2 generalized tonic-clonic seizures per year versus not having generalized tonic-clonic seizures increases the risk of SUDEP by 5-fold. So you start with something like 1 per patient per 1,000 patient years, or 1 SUDEP per 1,000 patient years. With 1 to 2 GTCs per year, you're up to 5 times that. With 3 GTCs per year, you're up to 15 times that. So further conclusions include seizure-associated factors, that seizure freedom versus seizure remission really decrease the risk and the incidence of SUDEP. So are you starting to see how these conclusions now could inform recommendations? Okay. They sort of come together with like a body of recommendations about GTCs. This is the Salanpa paper. They had 23 cases of SUDEP in the population of 245 people that they looked at. Absence of 5-year remission was a significant SUDEP risk factor. And then another study, or 2 studies, showed the same increased risk if the patient was not seizure-free for 1 year. So prolonged periods of seizure freedom are really what we aim for. Now, with AED factors, so those are the seizure factors. Here's AED factors. We did not find evidence that a specific AED, there's been some concern about lamotrigine increasing the risk of SUDEP. We did not find strong evidence for a specific drug or lamotrigine. However, from one class 1 study, we made the conclusion that it is likely that using a previously untried anti-epileptic drug in people with highly refractory epilepsy, such as those enrolled in clinical trials, decreases the risk of SUDEP by 40 to 95%, with moderate confidence in the evidence from one Class 1 study. So we only have one Class 1 study, so it sort of anchors us in a likely versus highly likely recommendation. So keep this statement in mind as I show you this study, and think about what you think about this study. So this study was published in 2011. It had a lot of influence. It was the first author, Rivlon, and they did something very novel and interesting. They looked at all of the double-blinded placebo-controlled randomized trials of add-on AEDs in adults with uncontrolled GTCs from either generalized or focal epilepsy. There were 21,224 patients and 5,589 patient years. They used 27 AEDs. 20 patients had SUDEP in this body of patient years out of a minority, actually, of the clinical trials. So looking at the rates of SUDEP, this is from clinical trials, from the patients who got a drug for which they achieved a therapeutic dose versus placebo. So the rate of SUDEP was 0.9 in those who received efficacious AE doses, and 7 times that in those allocated to placebo. So this decreased, so obviously getting a drug versus placebo reduced the risk of SUDEP. So how do you take this paper and do you use it, or do you say it's not generalizable because it's a bunch of patients in a clinical trial? Is the intervention generalizable? Do we use drugs the same way they use in the clinical trial? What does therapeutic dose mean? Can this study be used to prompt more aggressive treatment of intractable epilepsy? And then the question is raised from this study, should we even do placebo-controlled trials because they have such a high risk of SUDEP in the placebo arm? But so what we eventually ironed out from this is, obviously you have to do placebo-controlled trials. That's, I don't know if we should, giving a placebo is the same as not doing anything, which is what happens which unfortunately is the experience of many patients. But can we generalize this data? I think we decided yes, and we decided that it informed the concept that you should be more proactive, that you should continue to try anti-seizure medicines to reduce the risk of SUDEP for intractable epilepsy. So the AED factors are, it is possible, these are our conclusions, that a lack of AED treatment in epilepsy is associated with an increased SUDEP risk. That's from the Rivlon paper. It is possible that epilepsy treatments with a higher number of AEDs is associated with an increased SUDEP risk, but we downgraded that because it's hard to know whether taking more AEDs is just a surrogate for refractory epilepsy. Changing doses is another AED factor that we found is associated with an increased SUDEP risk. So that also could be a surrogate for intractable epilepsy, but what does this mean? How do we use this information to guide therapy, to guide management recommendations? Probably this factor suggests that you have to be really careful when you change meds. You have to make sure that the patient is always on a therapeutic dose or has a therapeutic level. So why does SUDEP occur? This complicated slide here really just points out through Hestrover's analysis that it's really the seizures and not the drugs. But this paper from Langen, which did not really inform a strong recommendation, but I actually like it because it points out this fourth bullet here on your right-hand side. If patients never took any anti-seizure medicines, their risk of SUDEP was 21 with a very high confidence interval. So, that argues that yes, you should treat patients, even though we didn't necessarily find that low levels of AEDs in the blood, in the hair, were found to be associated with SUDEP. But this does support the idea that we should treat patients at therapeutic doses. So other factors, it is highly likely that nocturnal supervision in the presence, in the bedroom of another individual with normal intelligence and at least 10 years old is associated with a decreased SUDEP risk. Moderate confidence in the evidence because of the magnitude of the effect. Just having somebody in the room, and the second point, or using a listening device, reduced, and somebody coming and checking on that person, reduce the risk of SUDEP by 20% to 80%. So these are from one class 2 study. So one class 2 study is not a lot of evidence, right? But because it's such a powerful effect, we upgraded the conclusion. Does that make sense? Okay. It is possible that nocturnal seizures are associated with an increased SUDEP risk as well. When does it occur? It often occurs during sleep because nocturnal seizures are a risk factor. And it occurs, SUDEP often occurs between 4 a.m. and 8 a.m. And there are papers about the positioning of people. Should we have our patients sleep on their backs? And really, I don't think that really matters, because what really matters is how they end up after the seizure. If they end up in a prone position, that does appear to be possibly a risk factor for SUDEP. How you start out to go to sleep is, I don't know if that would have an influence on the outcome, because what really matters is the type of seizure that they have. Do they flip over and end up in a prone position? And that appears to possibly be important, although we didn't find that in the guideline. Now, I want to go over this because it relates to this idea of having somebody in the room at night, which is, I think, kind of a radical idea, and monitoring patients at night. And now, as over the last year, we have a couple of devices that have come out. Brain Sentinel has produced this device that detects shaking during the night. There's a couple of devices that detect shaking. This may be revolutionary for helping patients to prevent SUDEP. At least it's a sort of minimally invasive way where SUDEP can be, generalized tonic-clonic seizures can be detected, and then the patients can be checked on. But this study shows possibly why a SUDEP occurs. So this is a study, again, from Rivlon. He's contributed some of the most interesting data to this field. These are cardiopulmonary arrests within EMUs, right, throughout the world. And there were physiologic monitors on these patients. They don't ever say in the paper whether they had a nurse looking at the patients continuously, like most of us probably do these days. So that actually they probably didn't have 24/7 video surveillance. But what you can see here, after a cardiopulmonary arrest, after a generalized tonic-clonic seizure, there is some transient apnea, and then followed by terminal apnea. And often what you see here is asystole occurs here at the end. So what you have is what it looks like in these SUDEPs where physiologic monitors were in place, is that you have this respiratory suppression, and then followed by bradycardia and terminal asystole. So it's sort of like it's a pattern that appears to occur after a generalized tonic-clonic seizure, and they identified near SUDEPs, patients who were interrupted in this phase survived. So this clearly points out that there is possibly a point of intervention where you can reverse SUDEP, and this is the biologic plausibility for why somebody in the room looking at the patient, checking on them after a GTC, or having a detection device that lets somebody in the home know that a GTC occurred during sleep, and they can go and check on the patient. This is biologic evidence as to why that's plausible in reducing the risk of SUDEP. I don't have too much more time, so I'm not going to go over this too much, but there is a great interest in genetic contributions to SUDEP. As you know, most of the things that we deal with in life, in our practice, are multifactorial, and the outcomes and the clinical scenarios are influenced by genetics. This one appears to be no different. Most of these genetic variations that are associated with SUDEP are channelopathies. I think SCN1A is probably the most important, given that 80% of people with Dravet's have this particular genetic variation. Dravet is a highly lethal syndrome, and 59% of the people who die with Dravet's have SUDEP. They die from SUDEP. So this seems like a really important model for a genetic contribution to SUDEP. So why does SUDEP occur in the older patients? Given that they may be more vulnerable to the physical stress, central mediated suppression of cardiac and respiratory functioning following a GTC, they may be more vulnerable to that as well. The literature also discusses variations in serotonin receptors. Serotonin receptors are activated with hypercapnia and can help to stimulate breathing in the setting of hypoventilation. If there's a genetic defect in the serotonin receptors, perhaps that contributes to SUDEP. And that's been shown in animal models, actually, that Prozac actually prevents SUDEP in animals. So that's another avenue of research. Is Prozac important? So why does SUDEP occur? Can we interrupt the cascade? So I showed you this already. I'm not going to go through this again, but here are our conclusions on other factors that did not inform recommendations. Non-lateralizable or extratemporal epilepsy possibly increases the risk of SUDEP. Does that make any sense at all? Is that biologically not plausible? We thought about this a lot. It may be plausible, right? That if you have frontal lobe epilepsy, if you have insular epilepsy, is that going to put you at more risk for cardiac abnormalities? Heart rate variability, we found little evidence. We found not strong evidence altogether for male gender, although that's been out there, or intellectual disability, although those two things were both found in the recent Swedish paper. Unfortunately, we could not find evidence that a good surgical outcome reduced the risk of SUDEP, but there were wide confidence intervals. So we could not, when the confidence intervals go from like 0.9 to 7, what can you really say about an outcome? It could be low, it could be high, it's insignificant, but it doesn't mean that there's not an effect. Basically, we didn't find sufficient evidence or conflicting evidence for these risk factors. So I gave you the strongest confidence, the conclusions, with the strongest confidence in the evidence concerning the risk factors. These include having GTCs, having more GTCs, not being seizure-free, not adding an AED when patients are medically refractory. And this is specifically from the paper that looks at clinical trials, right? So we included this. You know, if you did these guidelines, you might exclude it. You might think it's not generalizable, but we did. Nocturnal supervision, nocturnal listening device. Odds ratio is less than 1 there because they decrease the risk of SUDEP. So these are our conclusions, and we made 3 more recommendations. So again, in our process, a conclusion doesn't necessarily lead one-to-one to a recommendation. This body of conclusions regarding risk factors led to these recommendations. For persons with epilepsy who continue to experience GTCs, clinicians should continue to actively manage epilepsy therapies to reduce seizure occurrences and the risk of SUDEP, while incorporating patient preferences and weighing the risk and benefits of any new approach. Okay, so that tries to be very balanced. It doesn't, remember the paper that we based this on was specifically clinical trials, drug versus placebo, but we expanded our recommendation to include epilepsy therapies, which could be surgery, which could be RNS. So this is the latitude that we took. For persons with frequent GTCs and nocturnal seizures, clinicians may, this is a lower level of obligation, advise selected patients and families, if permitted by their individualized epilepsy and psychosocial circumstances, to use nocturnal supervisions or other nocturnal precautions, such as the use of a remote listening device to reduce SUDEP. Okay? Clinicians should inform their patients that seizure freedom, particularly freedom from GTCs, which is more likely to occur with medication adherence, is strongly associated with a decreased risk of SUDEP. So you can see this medication adherence part, we didn't actually find that in the evidence. This is more like a principle or an inference. So we are allowed to use this latitude in forming recommendations. And by doing that, they're more sensible, I think, because we actually did not necessarily find that medication non-adherence, but we know that if people take their meds, they're more likely not to have seizures. So I really dissected for you, I think, the guideline process, what we found, and our recommendations and how we derive those recommendations. So I hope that was interesting for you, and I appreciate your attention. Thank you.
Thank you very much. I have a couple of questions before I turn it to the room, if there are any questions from the room. One, I think you answered it during the course of your talk about seizure monitoring devices and the watches that detect the generalized tonic-clonic seizures and whether they have a reasonable expected role in reducing SUDEP by notifying caregivers.
I think so. I mean, we put together this data along with the likely process or cascade by which SUDEP occurs, and if you can interrupt that, it seems like people survive more. So that's where I think the answer is yes. I mean, I think it's just extremely fortunate that there are some more livable ways to detect GTCs during sleep now being developed, and hopefully they'll be, utilized. Maybe they'll help.
Another question is, you mentioned the incidence of SUDEP in childhood and in adults, in children and in adults, but among adults, is there a higher risk for those whose seizure onset age was in childhood compared to those who have a later onset?
Well, we did try to, I hope that this question addresses that. The incidence of SUDEP, including SUDEP, incidence of people with childhood onset epilepsy, including SUDEP occurrences after childhood. So it's about 1.2, so it goes up. But the SMR kind of goes down, as you can see. So I don't know, people who survive their childhood years if it's not a severe enough epilepsy to cause death in childhood, people live pretty long. The recent paper, actually from the Salzburg Institute, showed elderly people who have lived with epilepsy for many years actually live longer than, a small proportion live longer than expected. So I think that may not be the truth based on small sample size, but it suggests that, if you live with well-controlled epilepsy, you can live, generally pretty a normal lifespan.
The last question here is about Philippe Rivelin's study of the incidence of SUDEP during clinical trials. The question which you raised is whether we should continue to do placebo-controlled trials, and the answer is yes, because that's how we introduce new
That's
medications.
my opinion.
But then the suggestions are, if you look at recent trials of newer generation medications, the inclusion criteria is like 4 seizures per 28 days in most of them. But then if you look at on pooled analyses of 3 or 4 pivotal trials of most drugs, you will see that the seizure frequency, the mean seizure frequency was like 12
Yes.
per 28 days. So one thing that may be attempted, although the numbers are too low for one to make great evidence, is to make the inclusion, is to exclude patients with very frequent seizures, so that if they're randomized to placebo, this may result in higher risk, or to exclude ones with frequent GTCs in particular, or to use pseudo placebo, meaning dose of the therapeutic agent, but it's a smaller dose of the therapeutic agent. I don't know if these suggestions have any room in future planning.
I guess I don't think. I think the idea about not doing placebo-controlled trials is my opinion, that I don't think we should, from this study as a blanket statement, not do placebo. But there are other ways now that we're trying to make these studies safer, right? We're doing historical control data. The FDA just did two changes in their strategy to extrapolate from add-on trial to monotherapy. I think some of the, I don't know if it's Briviac may be getting approved based on that, and also to expand at least the efficacy data from adults to children.
Correct.
So that will reduce the risk, I think. And I think there are some strategies that are underway. Should you use fewer? Should you use patients with fewer seizures? That's going to extend it depends.
It's going to enlarge the sample size in order to get, statistically significant effect, most likely.
Yes, or maybe prolong the duration of the study.
Okay.
Yeah, I have one question about the potential intervention. I think in one slide you showed about maybe 10 people who had the SUDEP during the monitoring with the breath and the EKG. So overall, my feeling is those pretty quick. Yeah, that's right. It's let's see how long. It's minutes, basically 10 minutes or something like that.
15 minutes, I think. 15,
right. So I guess my question is at home, because if it's a terminator apnea, and it needs a lot of intervention to do. In a hospital, you can do the intervention. At home, it's pretty much impossible to do that intervention. And also terminate a cardiac arrest asystole. I'm just not sure at home how many people can do that. In the hospital, the nurse basically after GTC, they turn the patient aside and make sure there's no aspiration. But even in the hospital, it takes time for people to come here to do all those interventions. I guess, except maybe some easy intervention people can do at home, prone position, change to supine. What else? Because it's in that quick phase, 10 minutes, people do those interventions, and it's not easy. My feeling is.
This is where the recommendation has a little bit of a leap of faith, because the data showed if there's a person in the room with normal intelligence greater than 10 years old, or there's a listening device, the risk of SUDEP was decreased. There was nothing about what they did, when they did it, So we're drawing, we're connecting the dots a little bit on that, and because this is such a catastrophic and unpredictable outcome, it may be reasonable to take these slight leaps of logic, but no, I don't know. You're right. If they're already in asystole, they're going to need CPR at home. But the idea is maybe that if the seizure is detected, that you're going and checking on them here.
Right, need to be very early too. Yeah.
So, I think I'm actually proud that we have developed these guidelines to be more user-friendly than they used to be. But that requires some leaps of faith and logic and using data from other fields a little bit and stuff like that. Remember, in the guidelines, when we do the systematic reviews, nobody can have any conflicts, totally, unconflicted. So as far as the conclusions, you are going to, by process, exclude some experts. So when we make the recommendations, we can have conflicted people who, there's many people who have conflicts, let's say, who are our best experts. So we need to include them as we develop the recommendations. So I guess what I'm trying to say is the recommendations are hopefully developed with experts, and that's how they are derived for consumption and the betterment of our ability to care for patients.
Thank you.
I've stunned you into silence as usual. Anyway, but thank you.
Thank you.